Why are advanced medical treatments such as brachytherapy not available in the public health sector? How quickly can you recover from a stroke? Hello and welcome. I'm your host, Dr. Mosam Tombeni, and signing with us today is Trifosa Nzolengwe. On Vital Signs, we'll focus on the improvement of patient care for stroke and prostate cancer patients in the public sector. Coming up on the program, we'll hear from a man who suffered a stroke and is still in recovery, as well as from a man who is currently in remission for prostate cancer, as well as the Cancer Association of South Africa that is pleased to hear of the advanced prostate cancer treatment that is currently being introduced in the public healthcare facilities. We'll speak to a neurologist from Steve Biko Academic Hospital about the recognition that they got about how they're improving the diagnosis, care and management of stroke patients. And lastly, we'll speak to the head of radiation oncology from the Charlotte Maxeke Johannesburg Academic Hospital about public-private partnership bringing treatment for prostate cancer to the public healthcare facilities, as well as speaking to the first patient who received this advanced treatment for prostate cancer. Do remember that you can be part of the show by asking the guests that we'll have on any question that you may have in your mind. Simply share your view on what we're discussing. The number to call is 011-714-0677 or 011-714-0678. We're also available on social media, so share your thoughts with us there at SABC Vital Signs on Twitter and SABC Vital Signs on Facebook. The show will continue right after this ad break. Welcome back to Vital Signs. Now, recovery from a stroke and, of course, adapting to a new way of life is gradual and demanding process that, of course, you want to go through when you're actually someone that is actually surviving and you want to move from being a survivor to surviving. Now, these are the words of Sean Foster, who suffered a stroke 2 years ago and is still in recovery. He sat down with producer Wandile Mfokeng about his journey. Take a listen.
I was at home and it was the 11th of January 2020. And I was doing woodwork in my garage with my wife. And she started laughing at me and she said to me, "Why are you speaking so funny?" And drooling on the floor. And I was unable to stand up. And then fortunately she realized within what they call the golden hour that there was something wrong with me.
44-year-old ex-C-suite executive Sean Foster from Johannesburg suffered a stroke 2 years ago while doing some work at home.
What I can remember is that they did get me there within the golden hour, which is the time that I need to, in order to be able to administer a drug called TPA, which dissolves the clot, which causes a stroke in your brain and prevents your brain cells from dying off any further.
Sean was diagnosed with ischemic stroke, which is known to affect one side of the body, and most commonly, it can affect your speech.
I suffered an ischemic stroke, which basically is a loss of blood to your brain for a predetermined period of time, so that your brain cells slowly start dying off. And I had the stroke on the right-hand side of my brain, and the way strokes work is that the opposite side is affected. So my left side, my mobility has been affected and my speech thankfully is fine.
Mr. Foster spent more than 5 months in hospital recovering. However, he says recovery from stroke for him is a daily struggle as he now needs to relearn some of life's simple things.
Emotionally, it is one of the most challenging things you will ever deal with in your life, because I spent my life building up my independence and hoping and dreaming, like everyone does, of a better future. And all of that to be taken away in one fell swoop. Because like I say, the stroke didn't only affect me physically, it affected me, my ability to earn an income. Because now I am disabled by definition.
Currently, Sean is volunteering at the Stroke Survivors Foundation of South Africa, where he gets support from like-minded people. And to better his mobility, he has joined a rehab center where he does some exercise.
I was discharged to a fantastic rehabilitation center in Benoni called Moorwheel, and I was placed under the guidance of a Dr. Hogg there, where they place you on a plan for stroke recovering victims, which includes physiotherapy, cognitive occupational therapy, all of that to try and reteach you. Because what basically happens with a stroke is that you go back from an adult to a child to your learning phase. Whether it's with walking or talking or driving, because you have to do everything from the beginning again.
As a member of the Stroke Survivors Foundation of South Africa, Sean encourages those living with stroke to find purpose in their lives by staying strong and not giving up.
You want to be able to go from surviving to survivor, and you want to thrive. And in order to thrive, you need to believe that you can do it, because it's not the end of your life. There is light at the end of the tunnel.
After the break, we'll speak to Dr. Louis Kroon, a neurologist from the Steve Biko Academic Hospital, about the recognition of how it has improved the diagnosis, care and management of stroke patients. Stay with us. Welcome back to Vital Signs. Now, the Steve Biko Academic Hospital Stroke Unit is the first and only internationally accredited stroke unit in South Africa. Now, the hospital was recognized for how it has improved the management of stroke patients. Now, the Tshwane-based hospital has developed techniques which reduce the disability effects of a stroke and prevent deaths caused by stroke. For patients who will be receiving this acute treatment, it is said that the average stay at the hospital is reduced from 30 days to 6 days. To talk to us more about these treatments of stroke, we're joined via Zoom by neurologist at the Steve Biko Academic Hospital, Dr. Louis Kroon. Dr. Louis Kroon, thank you so much for joining us today.
Great, and thank you for having me on the show this morning.
Good. So let's get into what a stroke is before we, move on with what the Steve Biko Academic Hospital has done. When you explain what a stroke is to a patient that has had one, or when you're doing these sort of preventative talks to people about what strokes could potentially be, what is a stroke?
Great, and I think it was nicely highlighted in the case that we just saw prior to this interview now. And stroke has basically been defined as a rapidly evolving syndrome characterized by a loss of functioning. Classically, this loss of functioning governs a loss of power, speech, vision, and as well as sensation. And this usually evolves over seconds. It usually has a vascular origin. That means that it's either due to a blocked blood vessel leading to what we refer to as an ischemic stroke, and then you can have a rupture of blood vessels, and that's what we refer to as a hemorrhagic stroke. So most of our treatment guidelines currently is aimed at optimizing ischemic strokes, because ischemic strokes account for about 85% of the whole stroke population as this blocked blood vessel. And this is where we are placing special emphasis currently on at our hospital unit.
Now, when we watch the incident, Mr. Sean Foster spoke to this idea of he was communicating with the people that he was living in the house with, and people kind of laughed at the idea that he might potentially, be joking, because he was slurring with these words, he was drooling, until the seriousness of the situation came about. So generally, what is the presentation of someone that has a stroke?
Yes, it's like I mentioned, it was you get this loss of functioning. So classically, you have the slurry speech, you get a loss of power in the arm and the leg. It usually affects one side only, and this is classically where we use the mnemonic FAST. That means so the letters in the mnemonic FAST usually accounts for what we see. So F and fast means that you develop asymmetrical face or face asymmetry.
Okay.
And that's the F for fast. The A means that you've got an arm drift or loss of power in the arm. And then the S is you get speech abnormalities. And then the T in fast is a reminder that it's an urgent case. And it's almost like you highlighted it as well. The quicker you get to management, the better the chances are for improvement. So classically, how we say is that every minute you don't treat a stroke patient, you lose 1.9 million neurons, 13.8 billion synapses. That equates to more or less to 18 kilometers of brain tissue that we lose. Every hour that we don't treat a stroke patient, they lose 3.5 years of knowledge that they gained throughout their life.
Sure.
And this is it just emphasizes the importance it is to treat stroke patients and to get to a hospital as quickly as possible. And a lot of times people don't know the importance of these for these symptoms, and they might even think that it becomes quite fascinating or funny for this person now to start speaking abnormally or not to develop facial asymmetry. Yes.
So who gets strokes in South Africa? Which population needs to be on the lookout for potentially getting strokes?
Okay, so we've got a unique a demographic of stroke patients that we see in our population. So we classically see a little bit of stroke patients that are on the younger age groups. So our current average age that we see on our side is about 45 years of age. So between 40 to 45 years.
Sure.
There are a lot of risk factors that play a role here. So we talk about those modifiable or non-modifiable risk factors. So non-modifiable risk factors would be, for instance, if you're a male patient, if you've got a genetic susceptibility to develop a stroke. Modifiable risk factors is usually lifestyle orientated. If you don't have a healthy lifestyle, don't exercise, don't manage your comorbidities. So, for instance, if you've got high blood pressure or diabetes or dyslipidemias, in other words, cholesterol, and you don't treat that accurately, then you're placed at a higher risk for developing a stroke. So those are usually the patients that we see that suffer from it. But because we've got such a high a burden of infectious diseases in the country, we also see and these infectious diseases can also predispose to stroke. Therefore, we get a little bit of a younger age group in our population that we see in the South African context.
Now, a lot of the time people will speak to their grandparents or a parent having had a stroke, but it was a process that they didn't initially recognize. So what should one do when they realize that a family member or someone they live with or someone just in the community is potentially having a stroke according to the FAST principles that you showed us? What should be done?
So the quickest thing is to get to a hospital as soon as possible. So it's really easy. Like I mentioned, you use that fast mnemonic, and if you test positive on this fast, then you have to get to a hospital as soon as possible. Like what I just mentioned, time is brain, and this is exactly what we see with stroke patients. So that in the case study they mentioned that golden hour. That means if you have had a stroke and you can get to a hospital as within an hour, you get management, the chances to be reintegrated back into society is very good for you. And if you do, and every minute that you lose this time window, then you have a higher chance to be disabled afterwards. So traditionally we say you have 4.5 hours to get to a hospital to get stroke treatment. So you've got a window of opportunity within 4.5 hours. Obviously, the quicker you get to a hospital, the better the outcome is going to be. But you have 4.5 hours. But at our hospital, we've been able to, and this is part of the stroke readiness diamond status that we just received, and we've been able to optimize this window to expand it even further to 9 hours. And this took a lot of interdepartmental collaboration and communication. So what we basically did was we improved the whole stroke supply chain, but firstly and foremost by rapidly identifying patients in the emergency department. This is under Prof. Engelbrecht, as well as the nursing personnel, and the emergency physicians. So we are able to quickly and rapidly identify these patients and get them for neuroimaging to be to decide whether they are candidates to get this medication. So under Prof. Lockhart, we have now been, and as well as the radiographers, we've now been able to expand this time window up until 9 hours, not from the traditional 4.5 hours, but up until 9 hours, as well as wake-up strokes. So that means you've had a stroke upon awakening. So if you wake up in the morning, you already have this symptoms that's characterized by loss of functioning, the facial asymmetry, the loss of speech, etc., then you can still be a candidate to get medication or for this treatment. And then also, if somebody finds you at home and it's a stroke of unknown onset, we can now specifically identify the tissue that's still at risk or salvageable for further stroke management. And then, and part of this diamond stroke readiness protocol that we've established, we also manage to get to minimize complications. And again, this is where the nursing personnel, Sister Maduna and Sister Nchanku, really plays a huge role in identifying those patients that have complications, that are at risk of developing complications, and therefore preventing those complications from happening. And this is what the whole stroke status is about, that we're currently working and have been rewarded upon.
Now, this idea of a golden hour is something a lot of people have spoken to, but you've spoken to this idea of a 9-hour window that you could potentially intervene. But what are the criteria you use to pick out a patient that does qualify to receive this treatment?
Okay, great. So the traditional thought, like I said, it's actually 4.5 hours. But if you have access to specialized neuroimaging services, so this is just a CT scanner with perfusion that's capable of providing perfusion-based imaging parameters, we can now identify and look at the size. We refer to it as the core. That's a dead necrotic tissue that's already established in the brain. We can look at that, and then we can look at the penumbra, which is the tissue that is still salvageable. And if we identify that there's enough tissue that is salvageable, then we can provide the treatment. So now that we refer to it as tissue is now becoming the real issue here, and not the traditional time-based reperfusion that we provide to patients in the classical old system that we used, and a lot of hospitals are still using. But now we've moved away from that, and now we give tissue-based reperfusion strategies, and that's usually governed by special neuroimaging. The software system that we got on our side now is called Rapid AI, which is a collaboration between an international facility, Stanford Hospital, and they've really been able to create this a system where it's an AI-based system that automatically identifies the strokes and then gives us the results to tell whether this person is still able to get medication. So this time window that I just mentioned is now even expanding up until 24 hours after the stroke has happened.
Sure.
But we're not there yet, but in the near future, we'll most likely be able to provide that such management to patients as well. But that will happen in the near future from now.
Now, it sounds amazing what you're doing, and all of this is sort of described in the initial diagnosis of the patient, that the patient is either found at home or experiences the symptoms, is brought by family very quickly to the hospital, is seen by the nursing staff, is seen by the doctors, is taken to radiology to get the scans, and then obviously treated. But how have you guys reduced the hospital stays from 30 days to 6 days? What has contributed to that?
Okay, so just to give you a little bit of a background, what we see, the amount of stroke patients that we see, or the burden of stroke that we see in the hospital. So classically, we see one stroke patient happening per day. So it's important to remember about the demographical status of strokes in the country. So stroke is the second leading cause for morbidity in the country and the fourth highest cause of mortality rate in the country, in our country. That's what we see in our country. Per year globally, there's 15 million strokes that happen.
Sure.
5 million people demise from strokes. They don't make it. That's a 30% rate of patients who don't survive after they've had a stroke. Just to compare that to the figures that we've now had with COVID and undergoing lockdown. So classically, we can actually see that we should be almost going into a lockdown on a permanent status because of strokes. So what we usually see at our hospital is we see one stroke patient coming in per day. And now that we are able to provide this management to this medication, that TPA that I referred to, that clot-busting medication to open up that blood vessels, now that we can provide this management to the patients, we're able to reintegrate them back into society with a minimalizing hospital stay as well. So that's how we managed to get it down from 32.5 days up until now a week in the hospital. The important thing here is also because we're actively screening for complications, the nursing personnel, together with the Stroke Angels collaboration initiative, they've been able to train our nursing personnel as well as the emergency doctor, physicians, and our medical students to actively look for complications. And once we spot that patient who is at risk for developing complications, we minimize this. And therefore, we're also preventing or shortening the stay in hospital.
Now, traditionally, stays in hospital for patients that had strokes were either caused by something or naturally the patient's condition wasn't getting better. So what were those factors that contributed to the patients having to stay that much longer in hospital?
Okay, so like I mentioned was the fact that they're now getting the medication. So in the past, so I said we get 1 stroke patient per day. So in the past, before we started this whole stroke readiness awareness supply chain, we saw so like I said, 1 stroke patient per day, but only in the total of per year, only 5 patients got management for strokes.
Sure.
Now we're working at 30% of our stroke patients are getting that necessary clot-busting medication. So we've increased from 5 patients per year up until 30% of patients are now getting that per year. So that's equivalent to 360 patients, and 30% of them are getting this management per year. And like I mentioned, was we're actively screening. So what happens is a person who've had a stroke, they can't really emphasize the problems that they have. For instance, if you cannot talk, you cannot explain that you struggle to swallow as well. And then what happens is patients will get food, they will try to eat, but then a little bit of food will go into the lungs, causing aspiration pneumonia. And that's a common complication that we see with stroke patients. And therefore now we're aware of this complication that's happening. Everybody in the hospital is aware of that. And a person first have to be screened as being able to swallow before they can get any food. The family brings in food before they can drink any medications, etc. They first have to be screened as being able to swallow. And this actually have improved the complication rate significantly in our hospital.
Well, we have a caller, Albert from Limpopo, if I'm not mistaken. Albert, good day.
Hello.
Le kae papa? Re teng papa. Go tswa ke eng papa?
I was sitting in the middle of the car, 11:31. I had something like to me, it was like 3. Then when I got to the hospital, they said to me, it's Daryl's palsy. But now I've got my right hand to walk.
Albert?
Hello.
Yes, sorry, continue. Your question?
My venture is hot. And it's now the 5 months is hot.
Okay, I'm really struggling to hear what Albert's question actually is in this case. But maybe, Doc, let's chat around this idea of other problems that may present as strokes. I think what Albert was suggesting is that he presented with a facial asymmetry at some point, went to hospital and was eventually then diagnosed as a Bell's palsy, which is then naturally something that's ENT related. So in terms of assessing these patients and, of course, the window that you would have looked at, if you're seeing this patient and the patient goes to neuro imaging and the results come back as negative, and of course there are other things that go on about it, I think we could open up the question to something a little bit broader. What should other hospitals do in order to recognize strokes much better?
I think that's a good question. So the first thing is, again, to have a lower threshold to diagnose strokes. So yes, that's completely true. A lot of patients are stroke mimics. So is there any harm in giving this medication to a person who are having a stroke mimic, for instance, a Bell's palsy? So no, the short answer is no. These persons are not at a high risk of getting complications, even if you've by mistake given the medication to a stroke mimic. But again, the importance here is not to understand, because these people who've had a stroke struggle to articulate or try to communicate even. So therefore, they classically, because they do not scream or yell or get angry because they can't get communication, they've lost this function to communicate. Therefore, they are usually shifted a little bit as being non-urgent. And I think that's one of the biggest problems that we have currently, is that people that a stroke is not being seen as a medical emergency. It's similar to a person who have undergone cardiac arrest. We've lost oxygen supply that goes to the brain or cerebral hemispheres. So we've got this hyperperfusion. So the brain is starting to lose those axonal fibers. And if we don't restore it, this person is going to be very disabled afterwards. So the first thing is to make everybody aware about the importance of stroke management.
Yes.
And that we can, if we give it in the time frame, it's possible to reintegrate that patient back into society with minimal disability.
Yeah,
so that's therefore
I'm going to have to jump in there, Dr. Kuren. We're out of time, but thank you so much for joining us today to really discuss what the Steve Biko Academic Hospital in Pretoria is currently doing with respect to treating their patients from 30 days to 6 days for some of the patients in terms of a hospital stay, and of course, all the interventions that they've put in place to make sure they recognize as well as treat all the patients that present with strokes. After the break, we'll continue our discussion speaking to cancer, and that was Lorraine Govender, and this is what it's all about. We'll see you after this. Welcome back to Vital Signs. Now, Lorraine Govender from the Cancer Association of South Africa is pleased that brachytherapy is being introduced to the public healthcare facilities. 61-year-old David Lucas, who's also diagnosed with prostate cancer and now hopes to speak out about this disease so that he may induce men to get out there and get screened. We spoke to both Lorraine and David about brachytherapy. Let's take a listen.
Lorraine, thank you so much for joining us on Vital Signs. Thank you so much for giving us your time.
Thank you for having the Cancer Association.
Could you just kindly talk to us, man, about the current cancer treatment for patients who are living with cancer? What type of treatment right now is available for them?
I think it will be good to just talk about brachytherapy for now. So brachytherapy is also one of the treatment options available for treating men who have prostate cancer. And this includes tiny metal pellets containing radioactive iodine or palladium that are inserted into the prostate gland via needles that enter through the skin behind the testicle. As with 3D conformal radiation therapy, careful and precise maps are used to ensure that the seeds are placed in the proper location.
With regards to the new technology or rather new advancements, let's talk accessibility and affordability. Or do you see it being something that anyone can afford to undergo such treatments?
The Cancer Association is so grateful that this treatment is available in the public sector. And even if it's just being tried out and may not be available all over, but the fact that our public health system is looking at this, we encourage men to go in and have their testing.
So what we're looking at. David Lucas was diagnosed with prostate cancer back in 2011. He was fortunate to receive treatment immediately while his cancer was on stage 1.
I am very fortunate that at that point in time, I was in stage 1. And I received what is known as brachytherapy. As I explained, the seeds being planted. Then it did not work out too well because there was still a raised level, which the doctors were very concerned that it would escape and then, from the prostate into the rest of the body, into what they call lymph nodes. And I received radiotherapy. Now, I was in a very fortunate position, but I must also say to you that when this happened, our medical aid at that point in time did not cater for brachytherapy.
Brachytherapy is an advanced prostate cancer treatment which can be used alone to cure early stages of prostate cancer.
It is great that public hospitals now are doing brachytherapy as well. I'm aware that the most major, and it's not the procedure that's being done and in fact most of the cancer treatment is not done in the sort of peripheral hospitals. It's normally the academic hospitals in our country. And I know that they do that. They obviously will do radiotherapy, they will do chemotherapy, they are hormonal treatment. And, some of the top-notch specialists are at these hospitals. They know what to do. They see the patients on a daily basis, obviously a lot of patients. And yes, we all know our health system is under pressure, but the treatment regimes that I spoke about are available within our public health care system. In South Africa, we are actually at the forefront of cancer treatments.
After the break, we'll speak to Dr. Duven Ramia, the head of radiation oncology at Charlotte Maxeke Johannesburg Academic Hospital, about the private-public partnership bringing treatment for prostate cancer to public healthcare facilities. And we'll also speak to Patrick Vaughan, who's the first patient to receive advanced treatment for prostate cancer. Stay with us. Welcome back kuyo yena i-Vital Science. Namhlanje sikhuluma nge-stroke nayo ke i-prostate cancer nazo zonke izinto ezenzakalayo la ku-public health enina ke ningathola usizo ngayo. Earlier on eshowini yethu besikhuluma nodokotela osebenza e-Steve Biko Academic Hospital wakhuluma ngendlela eziningi zakhona la bakhona ukusiza abantu abathola i-stroke ngakhona. Okwamanje ke isikhathi ukuthi sikhulume ke nge-prostate cancer. Into enkulu ebalekile eyenza ke ama-problems amaningi ebantwini abantu besilisa. So sibona ukuthi ke kube important kakhulu ukuthi sikhulume ngane ngako lokho ke. So a private public partnership will see 12 state patients that have prostate cancer receive advanced cancer treatment known as low-dose rate brachytherapy at Charlotte Maxeke Johannesburg Academic Hospital. Now, prostate LDR brachytherapy is a treatment which can be used alone to cure early-stage prostate cancer or combined with external beam radiotherapy for slightly more advanced cancers. Joining us to speak about prostate cancer and, of course, the advanced treatment brachytherapy, we're joined by Charlotte Maxeke Johannesburg Academic Hospital Head of Radiation Oncology, that is Dr. Duven Ramaya, as well as Mr. Patrick Vaughan, who's the first patient to receive this advanced treatment. Thank you so much for joining us.
Thank you.
So let's start with you, Doc. You know, this idea of prostate cancer is such a big one that gets very little attention because it isn't flashy and also isn't something that a lot of men want to talk about. So when you speak to a 40-year-old or a 50-year-old, you know, speaking about prostates and, you know, the exams that come with prostates isn't something they generally want to get into. So let's speak around prostate cancer. What is it? Who's more at risk of getting prostate cancer? And why is it such a myth and you know, this mystery to talk about?
Well, thank you very much for having me. Yeah, you know, so prostate cancer is the second most common cancer in this country, the most common cancer in men. So it's an important cancer that I think everybody needs to be aware of. The reason why it probably doesn't get as much flash as some of the other cancers is because it is a more slower growing cancer. But the important thing about it is that it is very, very curable. That's important to know. And if it's caught early, there are a lot of treatments that are available which can cure the cancer and are actually not that, that don't affect your quality of life all that much, but it needs to be caught early. So the important thing for men over the age of 40 is to get screened, which involves a prostate-specific antigen blood test and a digital rectal exam. Now, I know men don't like having the rectal exam. Right? Doctors don't particularly like doing them either.
Not at all.
Yeah. So, you know, but it is important, and those two need to be used in combination with each other. You know, if you just do the prostate specific antigen test, you can miss potentially about a quarter of your prostate cancers. So it's important that they be done together with each other. The usual guidelines are for men to start screening at the age of 45, and those are the international guidelines. But if men are at higher risk, it's usually recommended that they start screening at the age of 40. And we know that black men have a higher risk, so they need to start screening at 40. And if there's a strong family history of cancers or any genetic abnormalities that you know of in the family, then again, you should start screening at 40. And it's important because it's very, very, you can catch this early. The prostate-specific antigen test is very effective. So it's important that men go out there and get tested. And if you're tested, there are treatment modalities available to cure this cancer.
Now, Mr. Vaughan, you're one of these people that decided to go get tested. But of course, something has to push you towards going to the hospital or being examined and being seen. Take us through your story.
Yes, thank you so much for having me. Yeah, I lost my dad and 3 brothers due to prostate.
Sure.
So I was a high risk. So I started screening at 40, and as annually screening, and then at 60, there was a trace of cancer, of prostate cancer, and that's where we went through the process. Yes.
Now, before this, naturally, you know, especially with someone who's got a high risk, you're told of the different symptoms and things you must look out for.
Yes.
But those are generally quite tricky to have, especially with males, because
Yes.
people won't necessarily notice that their stream isn't as strong as it used to be and things such as that.
Yes.
And so what, apart from the history, what else were you told to look out for?
You know, all these, I had no side effects. I had no problems, nothing.
Nothing
With the
at
stream, nothing at all. There was no blood in my urine or, you know, nothing. I was just as a normal human being. And the trace was there. Just because I knew that in my family, the history, you know.
Of the prostate.
Of the prostate, yes.
Okay, well, we're continuing to hear what you have to say. As always, we've got Johannes from Limpopo with a question. Good day, Johannes.
Hello.
Hi, sir. How are you?
I'm good, and you, sir?
Good, thank you. Sorry, what's your question?
My question is that I've been to the hospital and then they say my PSA is now 4 point something. They put me on the Eurodogs now. And then when I go after 6 months to check on it, and then it raised to 7.5. And then they go for biopsy. And then they say it's not yet a prostate cancer. So I'm now frustrated what to do and what must I do, because it's now increasing the PSA level.
Okay, thank you so much for your question, Johannes. The doc will answer you just now, okay?
Yes,
So
sir.
that idea is something that you've lightly touched on now, the idea of cancer versus a more benign, non-problematic thing that results in an increased PSA. So for everyone at home that doesn't understand what a PSA is, it's basically a blood test that is done to see what level of this tumor marker is in the blood. If it is high, then of course that points towards something. If it's low, that means that things may be relatively normal. So this idea of a raised PSA and going multiple times to the hospital and then being told, no, everything is fine, we'll see you maybe in a year or two continuing the test. What is the difference?
So I think it's important to know that a PSA is not a diagnostic test for prostate cancer. It's a screening test. It's a very good screening test, but there are other things that can push a PSA up. We know that a PSA goes up as men get older. Prostate generally enlarges, and it's usually a good marker of the amount of prostate tissue in the body. So the PSA can go up because of that. There's also other causes that can cause a PSA to go up besides benign prostate hypertrophy, things like an infection of the prostate, etc. But you know, in this case, you know, if the PSA is up, what you need to do is then you correlate that with your digital rectal exam. If there's a suspicion, either because the PSA is very high, and I think the caller said the PSA was about 7, then you may want to then go on and biopsy. But a biopsy will confirm if there's cancer or not. Sometimes it can be that the prostate is just, that it's benign, that the prostate is just enlarging because of a benign cause. And then, of course, you can continue to watch, and there's various medications that you can take which can help to increase your urine flow, to help to shrink down the prostate a little bit. But yeah, you know, it's actually a good thing, you know, if the biopsy comes back as negative. The PSA screens, but the biopsy will confirm. The PSA plays other roles as well. The PSA also helps us direct treatment as well, so we can decide on what the appropriate treatment is, etc. But in this sort of scenario, the PSA is used as a screening, but it's not diagnostic.
So let's speak around the symptoms that a patient would generally come out with, because a lot of the time people, like I mentioned a bit earlier on, aren't aware of these things. It's always associated with, I'm aging, so things are supposed to look a little bit like this. So what are the things to look out for if you are thinking potentially there could be a prostate cancer?
So it's important that a lot of patients present like Mr. Vaughan with absolutely no symptoms at all, and are usually picked up on screening. The important thing about that is usually those are very early prostate cancers, and they're very, very treatable at that time. And also there's a lot of treatment options, so patients can then decide on what is their best, what's the treatment road that they want to go down. If the cancers are a bit more advanced, usually there's obstructive urinary symptoms, and by that I mean patients may find that the urine stream is getting a little bit weaker. They're finding it difficult to initiate urination. While they're urinating, the urine stream is stopping and starting. Or they might find that they're going to pass urine a lot more often, or they're finding it very difficult to hold their urine. You know, so usually those are obstructive and slightly irritative symptoms that can come up with prostate cancer. the stage we don't want it to get to is where you suddenly find you can't pass urine and you've got to go to a hospital and have a catheter inserted because the urine just absolutely won't come out. And usually by that time, if that does happen, then it may be too late for treatments like brachytherapy, etc. So we don't really want it to get to that stage. So if you're finding these symptoms, it's a good idea to get it checked, have a PSA done, have a rectal exam done with your general practitioner, and then just make sure that your prostate is healthy and hopefully is just a bit of enlargement that happens with age. But it's important to make sure that it's not cancer.
Now, Mr. Vaughan, you have this positive family history. You're talking about your dad and brothers. They have been told and they had prostate cancer. You do the test and the result comes back and it says that you also have prostate cancer. Take us through that journey and how you were feeling at that point in your life.
Well, I was prepared because it's family history. I was told, prior to my screening, and that I can have a prostate later in my years. So yes, I went for the screening, but because it was in the family, I knew that I had to take the risk. And I had to go to hospital and do the necessary tests and so forth and be prepared for whatever they're going to tell me. But fortunately then, it was just enlarged or infected. So I had treatment for it, antibiotics and, the medication that they give. So that helped me over the years until maybe 20 years later, they discovered that no, now you have to come in for brachytherapy or whatever treatment they had, the options they gave me. But brachy was the best for me. So yes, I was prepared, like how I do now, telling my children, my other siblings, that it's it can be prevented. If they detect it early, you don't have to go the route of my dad and my 3 brothers.
Very important information there. The idea of treatment is one that a lot of people would be very scared to start having. The diagnosis in itself is scary, but the idea of treatment options is also what. So what treatment options are available in state for patients that are diagnosed with an early and then maybe perhaps a patient that is separate, that is a late stage prostate cancer?
So currently in state for early stage prostate cancers, there is the available option of a radical prostatectomy. So that's the option where the urologist would generally cut out the prostate and the seminal vesicles. And that's usually appropriate for only a localized prostate cancer, early stage prostate cancer. The other option that can be used is external beam radiotherapy. So that's a treatment where you lie down on the radiation machine and there's radiation directed at the prostate and potentially also the seminal vesicles and any lymph nodes that need to be treated. So both those options are available in state. But obviously there are resource constraints with that, which has led to slight waiting lists for actual treatment. So it's important that we bring in the third potential treatment for prostate cancer, which is other than external beam radiation and the surgical option, which is brachytherapy. So brachytherapy is where there's little radioactive sources, we call them seeds, which are then put into the prostate, and those seeds emit radiation and can kill off any cancer cells within there. So those are the options that are available. Brachytherapy is new. We introduced it at Chris Hani Baragwanath last year, mainly because, well, we were supposed to do it both at Charlotte and at Chris Hani Baragwanath, but due to the fire at Charlotte last year, we delayed it slightly until this year. But those are the options that are available. So it is available at Charlotte and Chris Hani Baragwanath. The problem is that what we find is that on the waiting list for treatment, a lot of patients are actually not candidates for these treatments because you've got to have fairly early stage prostate cancer. Once the cancer has broken beyond the capsule of the prostate, has gone beyond the prostate, has gone into seminal vesicles or spread into a lymph node, then this treatment is no longer appropriate. So what we're finding is that even though we have it available, there's not a lot of patients that actually are qualifying for this type of treatment.
We've got Temba from Soshanguve. Temba, kunjani? Siyaphila baba, ungabuza umbuzo wakho.
Yeah, yazi kusho ukuthi incline ubheka ukhona manje la manje ne. Nginenkinga la ngifuna ukubuza ukuthi ukusho ngabe endlelo bewe bachaza ngakhona. Ngithenzani uma ngikhipha amanzi kuba buhlungu and then ngaya edokotela bangifika edokotela bangifaka ipipe la ngaphambili yabangifaka ipipe bathi bafaka ipipe lapha ipipe laya malifika lephakathi entweni la lema la ngasakuthuleki phambili idokotela wangitshela ukuthi ipipe leli belifanele ngabe liyaphelelela lana epenyithini yakho manje kwaphela ukuthi alipheleleli la bese walikhipha bese wathima no wangiletha ukuthi ngiye eJoji Mkhari ngaya eJoji Mkhari
yebo
mangena eJoji Mkhari bangifaka elinye lapha eJoji Mkhari bangibuza bathi noliphi la pipe ngathi no azange banikeze lona lela pipe lela bese bangifaka lapha ipipe lela linamanzi ngaphakathi baliyenza bese bathi no la kimi lana ungathi la phakathi le phakathi le kusho ungathi ungamulile that is why and manje ungangikhama umkhamo wami uyayenza awuphumi kahle uma futhi abana inkinga yami and manje uma ngikhama kubuhlungu
kubuhlungu mawuchama
and manje sokhona manje yebo
siyabonga Themba ngizobuza udokotela and nizochazela ukuthi kanga kufanele kwenzeni okay.
All right.
So Themba Shanguve describing what was an issue of dysuria, where P was very, very sore, that he was having issues urinating, where he was just forcing the urine out and nothing was happening. Went to go see a doctor. They tried to put a catheter in and it was stopped, and then went to another facility where he was helped out. But he continues to have this issue of painful urine and obstruction at the same time. So classically, with what I'm describing to you, what do these patients have and what should be done?
Yeah, so these are symptoms that could potentially be a prostate cancer, but there's other causes that could potentially cause this as well. So obviously things like a prostatitis, which is an inflammation of the prostate, even things like urinary tract infections, etc., can potentially cause this. So the important thing is to go through for testing. Usually, doctors would do a prostate-specific antigen when patients come in with obstructive symptoms, but could also do various urinary tests, etc., to try and actually ascertain what the cause is. If it's an infective cause, then usually those are quite easily managed with things like antibiotics, etc. But yeah, it's important to get it checked out and for it to be investigated properly.
Siyathemba ukuthi ke bowulalele Themba nokuthi ke uzohamba uyothola lo usizo bayenza ama-test afanele bawenze ukuthi uzokhona ukuthola usizo oludingayo. So back to the brachytherapy, back to this treatment that is available, but not a lot of people qualify for. What numbers are you able to treat in an ideal world should people, find their cancers early, have not the cancer spread past the capsule and into the lymph nodes and things such as that? How many numbers can you possibly treat?
So currently at Chris Hani Baragwanath this year, we are aiming to treat 50 patients.
Okay.
So that'll be 50 patients in Chris Hani Baragwanath. And at Charlotte, we've started the program recently. We will treat 12 before the end of the year, and then hopefully we will continue it at Charlotte next year, hopefully for about 50 patients as well. And we're finding that for the patients that we have diagnosed with prostate cancer, even though there's a lot more patients, the patients that qualify for brachytherapy, that's probably about the right number for them.
So what is limiting to the number of people that you can treat? I mean, 50 in, when you look at the perspective of a year, seems like a small number, but naturally you could do more. So what's stopping the more from happening?
So if patients have a more advanced cancer, so if their seminal vesicles are involved, if the cancer is broken through the capsule, or if there's lymph nodes involved, anything like that, then usually external beam radiation together with androgen deprivation, which is an injection to block testosterone in the body, would be a more appropriate treatment.
Okay.
Also, the urologists like to do radical prostatectomies on some of the patients. Generally, if they're younger men, etc., they might want to do a radical prostatectomy on those patients. So that's the other option. And then we also have external beam radiation, which we can use. We try and reserve that for the more advanced prostate cancer patients, but we can use external beam cancer treatment on more early stage prostate cancers as well.
Well, gentlemen, thank you so much for joining us today. We are out of time. I'm very happy for your good health at this point in time and coming here on the show to show men that it is possible, especially when you know the family history. But importantly, to the moment you hit 40, go out and start going for those screening exercises. And thank you so much to you, Dr. Ramaya, for coming out to tell us what the initiative, of course, to go out and give brachytherapy to these early cancers does, and of course, the benefits of it. Thank you at home for watching our show, and we hope that we've left you with a little something that you can take home, not only maybe for yourself, but for a family member, an uncle, an aunt, a brother, and whoever else, so that you can pass this knowledge on and they may be able to help themselves. This has been Vital Signs. Thank you so much for joining us. I'm Dr. Musa Mtombeni. Goodbye.